Well, good evening. Hello there and welcome. This is your Superstation Joy 99.7 FM. My name is Enimwa Enim Ado, and we're on until 8 o'clock. Thank you so much for joining us. Thank you so much for choosing to be here. We know that you could be anywhere else, so we're really grateful. And we're live on Facebook, so if you're not driving and you're home, you might want to join us over there. You can watch us, you can comment, send your questions, and all of that. But we're also live on WhatsApp. And today's show is quite interactive, so our WhatsApp lines are open. I'm sure you know the number, but a gentle reminder, 055 1111997, 055 1111997. So tonight I'm joined by Dr. Josephine Insafo. She is a senior lecturer, general surgeon, University of Ghana Medical School and Kolebu Teaching Hospital. She's joining us this evening because for the past 3 weeks, we've been hearing from breast cancer survivors. And in the process of hearing their stories, there have been little issues that have come back, and we thought, why don't we talk to somebody who is really, really at the front line of all of these different stories? So tonight I'll be asking her the questions that you've sent in already, but then we also are encouraging you to send your questions as well. Please don't show up here. We're not doing consultations after the show. If you need to see a doctor, just go to your healthcare facility. There's a process for it. So I would encourage you to do that. So good evening and welcome.
Hello, Enimwa.
Thank you so much for being here.
It's a pleasure. Nice to meet you.
Nice to meet you too. I've heard really good things about you.
Really?
So yes, I'm really excited about having you here tonight. But over the past 3 weeks, we've spoken to some amazing women who have been through the whole process, from the diagnosis to the surgery to the chemo to the radiation, to going into recovery and almost sort of living their lives on the brink of, is this going to come back? Is this gone away forever? So it's been a lot, but I want to start from the beginning. So with all the women that we spoke to, they all talk about having some sort of indication that there's something wrong, and then just being hesitant. So there's always kind of like a space with all the stories that we told. There's a space between, okay, there's potentially something wrong, and going to see the doctor. So I want us to start there. How important is it to see a doctor immediately? There is something unusual going on with your breasts.
Right. Extremely important. As soon as you notice something is not right, you want to get it checked out. Chances are it's probably not even breast cancer. Fingers crossed, but it could be. The thing with breast cancer is it doesn't wait. It spreads. So wasting time, dilly-dallying, is it not? I'm scared, I don't want to look, I don't want to touch it. It doesn't help anybody. The sooner you get it checked and sorted, the better. Because a lot of women have done that and have regretted. I think the average reporting time has been 10 months.
Wow. People
can sit at home with a lump or something wrong with their breasts for a year, more than a year, a few months. And that makes a whole lot of difference. Because the thing about breast cancer, it's not about having a lump in your breast or having blood from your nipple or any of those changes we talk about. But cancer cells are also in the blood. A lump in your breast is not going to kill you. It's the cancer cells that break away from the main lump in the breast, which are in your blood. And they don't make you sick. You feel very healthy, but they are lurking around. It's this concept we call micrometastasis. So they are just lurking around in your blood cells. And every type of cancer behaves differently. Some will be in your blood, and then they just enter your lungs, your brain, your bone, liver, wherever. And they take seed there, then they grow up. So imagine something chewing up your lungs. Next thing you know, you can't breathe, and then it's too late. So we need to start treatment early, not necessarily because of the breast, but because of the potential for cancer to spread.
Right.
And that's why we have to give all those treatments.
That makes a lot of sense. So, I mean, you can have the lump, you could have cancer, and you could be feeling fine.
Very well.
And wishing it away or anointing it away or something it away. And because you're feeling fine, you feel like, okay, it's not going anywhere. But if it's there, it's really not going anywhere, is it?
Oh no, it's not going anywhere, and it's progressing. So even there are people who, even to my surprise, with all the breast cancers I've seen, they come to hospital and I see this lump. I say, this is not bad. Just go do all the tests, the workup and everything, bring it, and then we can, take it away, solve the problem. They come, and then already on the CT scan, there are some tiny little lumps in the lung. Meanwhile, this patient is sitting there, breathing all right, doing great, and it's already spread. Even there are some cases that even I've been surprised, thinking, this lump is not that big. But it's not even about the size, but it's about the behavior of that cancer cell.
Wow.
Yeah. And so you can be feeling perfectly fine, not knowing you are sitting on a time bomb. So this person is all right, going about their usual business. Then one day, suddenly, they begin to feel a bit tired, a little difficulty in breathing. They come in, they do CT scans, and we realize that it's the beginning of the end.
Wow. So it's really important when you notice that there's something wrong.
Yes.
To go and see the doctor.
Exactly. But, Enimwa, I think it's high time we even stop saying when there's something wrong, go see the doctor. Elsewhere, they don't wait to feel a lump or anything wrong in the breast. They do screening. So screening is about picking it up before it becomes a lump.
Okay.
Or before it becomes a symptom. So when there's nothing wrong with your breast and you do screening, the proper screening is not just touching your breast or having a nurse or someone examine it. The best or the highest level of screening is to do a mammogram. There are some other things, scans and MRIs and all, they have their special indications. But the MRI is done routinely in developed countries.
Okay.
So from your 40th birthday, everybody once a year or once every 2 years, you do the mammogram. So they do this regularly. Then suddenly they notice it when it starts before it becomes a lump.
Okay.
And the mammogram is so sensitive, it picks it up.
Okay.
So at the stage before it becomes a lump, they take it out. And obviously they are going to have a cure. A lot of them may not need chemotherapy at that stage.
Yeah.
Yes, you might have radiotherapy or depending on the details of the cancer you have. So even the treatment is shorter, it's definitely curable, less expensive, and they survive cancer very easily because they get it before it becomes a lump or any symptom in your breast. And that's the best stage to even go get it sorted out.
A lot of people, a lot of Ghanaians would say, what you don't know doesn't hurt you, doesn't kill you. I've spoken to so many people who are like, I don't go for medical. Like, I feel fine. I'm not going to go for a medical check. I'm not going to for any of that. Because as soon as I know there's something wrong with me, then it's like, I'm accepting that there's something wrong with me. But as long as I don't know there's anything wrong with me and I feel fine, why do I have to go and see the doctor? It's a reason why a lot of women don't get their breast checked or the pap smears or the routine things. Is there any concept of that?
Oh, yes.
That is true. That is true.
Oh, true. I don't know if that's true, but I mean, ignorance is bliss. Everything is okay, hunky-dory, and we are moving forward. But then it just takes you by surprise, and it's a bit too late.
It's a bit too late.
Yeah.
There was another issue that concerned me in our conversations, and forgive me if I'm putting you on the spot, but for I think 2 out of our 3 stories, the women spoke about the breaking of the news, the being told. Okay, one of the women said that the I don't know what the professional name is, the person who does the mammogram, who was not a doctor, told her, oh yeah, it definitely looks like cancer, but go and see the doctor, and then the doctor will confirm. And then the other woman said the doctor said to her, just it's okay, so it's cancer, so here's your referral, whatever, and that was in the space of 2 minutes, and it was difficult to hear the almost lack of empathy that was shown in these cases. Now, I know that that's not true for every doctor, but I also felt like definitely it's a fear when you are not sure if you're going to have the adequate support. They all spoke of not having any sort of counseling, not having any follow-up calls, after being told the diagnosis. How do we fix that? How do we make the system more supportive, in those? And the women were like, so we left the hospital and we drove home, and we don't know how we got home because I've just been told I have cancer. How do we fix that?
Yeah, the women really do go through a lot. It's a genuine concern. So it also depends on the facility that was detected. I think it's a little careless for someone doing your scan to blurt out that, oh, this looks like cancer. We could do better. When you are at Korle Bu Teaching Hospital, you see, Korle Bu is a referral center, so it's likely somebody suspected it already. A doctor suspected it already and then referred you.
Okay.
Some even have their biopsies before they come to the cancer centers.
Okay.
So the news will be broken to them before they come to us at Korle Bu. I suppose we could all do a bit better, but sometimes too, it's because of fear. No matter how you try and cushion it for the patient, it's not an easy thing for the patient to take. Yeah. So no matter what you do anymore, with all the flamboyant whatnots and hugs and kisses around, the patient too will still feel like you were harsh, dropping the bombshell. I don't know. It's also a bit difficult. What do I say? I will tell you that, well, I've seen your biopsy report and you have breast cancer. There's no other way of saying you have breast cancer.
There's really no other way.
I actually have to say breast cancer. That's the easy part, if you ask me. You know what gets to me is telling you have breast cancer, but unfortunately it's in your lungs. I have to say it. I can't hide it. You have a right to know. In fact, you need to know to be able to fight it. It's in your lungs. It's spread already. We can't cure you at this stage, but we can do this. We give you chemotherapy. It's going to shrink. You're going to be much better. And by the time, we actually have to look in the faces of our patients and say this. Wow. That's why I'm pleading, come early and spare us both the agony of getting to the latter part of it. We have to convey that message, but we need to cushion it and show some empathy and all that. Where I'm working at, the workload is huge. Honestly, it's difficult for me to spend 1 hour per patient.
Telling them,
but we work in a system, and it's things that are different from they were 10 years back. We have breast care nurses, so they are dedicated solely to supporting breast cancer patients, and they've been taken through some training, some counseling and all that. They understand the disease much better. And then we have a clinical psychologist on our unit, and the amazing survivors who just come to every breast clinic. So what the system we have now where I am, when we open the envelope, I'll tell you that, look, you have breast cancer, all is not lost, we can do this, this and that. So from here, you go to room 9 and you see the ladies there. So the breast care nurses are there. They'll talk to them, more details about what they are dealing with, how to take care of themselves, the treatment options the doctor told you, the side effects, everything. Then you move to our clinical psychologist. She will also do her bit. Wonderful lady, supports them. They are able to break through certain barriers I cannot break through in the consortium, and the survivors there. The survivors are doing a great job. We talk less now because I tell a patient you have cancer. Some of them can freeze. You just freeze into a statue and they are staring. Some of them too are very emotional. Some of them too are refusing it in Jesus' name. There are different reactions. There are all sorts of reactions, and it's not funny. It's real.
Yeah.
You can feel the pain and all that. And I can tell a patient that we need to remove your breast. The patient says never. There's no need to panic. I said, calm down. We are not doing it today. It's a process. And then the patient is sent to the clinical psychologist and the survivors She spends just 10 minutes with the survivor. She comes back and she's, doctor, I'm ready. Let's do this.
Wow.
And they are ready to fight because they've seen somebody who's been through it.
Yeah.
The clinical psychologist is there. The survivors are there. They've seen somebody who's been through it. They know they can do it. And it's a sisterhood. They support each other. So doctors cannot do it alone. And we work in a system with our nurses, our psychologists, our survivors. And it's been very helpful for the patients and helpful for us as clinicians as well.
Yeah, I totally get that. So walk us through what the process, like the options. So you come in, you're told you have breast cancer. Then what next?
So after the counseling.
Yes.
And then there's the treatment.
Okay.
So what are the treatment options? So everybody's breast cancer is different. So everybody gets a different treatment.
Okay.
So depending on your stage, so has it spread or it has not spread? If it's not spread, great. Then we are aiming for a cure.
Okay.
And even when it's not spread, you have the very, very early ones and the not so early ones.
When you say the cure, because you said it a few times, what does a cure for breast cancer look like?
So today is our breast clinic day. So a patient comes in, nice old lady, she's 81. She said, she's coming for her annual follow-up. Go through her notes. She was treated for breast cancer 16 years ago.
Okay.
Yeah, so she, for instance, that's a cure.
Okay.
Then a young doctor asked me, so have I seen anybody more than 16 years? I said, oh, yes, all the time. We have some 20 years. I remember one lady about 30 years. She's really old. So a cure means a cure. That cancer shouldn't come back and bother you again.
Okay.
But we have seen people who we thought were cured, and 21 years later, the cancer came back. But imagine if you were 40 and now you are 61.
Yeah.
That's 20 good years in remission, and that's great. So by a cure, we actually do mean a cure.
Can you determine if it will come back?
It's very difficult. So if at the time it hasn't spread, if it's spread from the beginning, we know it's going to come back.
Okay.
It's just a matter of time.
Okay, so once it's spread, even with all the treatment, chances are that it will come back. There's going to be some fragments left somewhere.
It's going to come back.
Okay.
Yeah. So we shrink it, you feel better. There are some people who were even unwell because it spread, and they improve so much. They are so excited. I'm happy for them, but
you know that it will come back.
Yeah. And some have done very well, even with disease that spread, and they've survived more than 5 years, and they are, going on, which is great. But when we say cure, it's at the beginning, it hasn't spread, and then it doesn't spread. Can I tell who it will come back in 2 years, 5 years, 10 years? You can't really say. But what you do is you give it all your best, all guns blazing, do everything, chemotherapy, radiation, whatever. Once you've gone through all the treatment options, then we just pray and hope for the best. But the earlier it is, the less likely it is to come back.
I was just going to say that it really just looks like the one thing that almost guarantees that you'll be fine is coming to the doctors early.
Exactly. Because we have stage 1, 2, 3. In fact, let me start again. You have stage 0.
Okay.
Stage 0, 1, 2, 3, and 4. 4, it has spread. But obviously 0 and 1, the survival rate is better than stage 3. Yeah.
Wow. I hope if you're listening to us, you're going to get checked. Because I'm sitting here thinking, yeah, okay, maybe I should get checked as well. Because, well, like you said, you can get cured if you get it checked early. I mean, we'll continue with the process. So we'll move on to chemotherapy and all of that. But a few weeks ago, I was reading about the gene, the breast cancer gene. Apparently, there's a test that you can take at an early age, which will determine if you carry. I can't remember the name. It's something.
BRCA.
Yes, the
1 and 2. BRCA.
Yes,
we
exactly.
say BRCA 1 and 2.
So, do you want to just tell us a little bit about that?
All right. So those who have the genetic type, the hereditary type of breast cancer, it's just about 10% of cancer patients.
Okay.
So that means for about 85-90% of people with breast cancer, they don't have the gene.
Okay.
It's just a one-off chance and they happen to get it.
Okay.
So it doesn't make sense that everybody should just do that test, because it's only 10% of cancer patients who actually have that gene. It's very expensive.
test.
Yeah.
Okay.
Maybe I don't know. I don't know if it's about $2,000 or something. It's not done in country, though. I think one or two labs either are preparing to set it up.
Okay.
Yeah. So you can't get it done. It's pretty expensive. Even if it's not expensive and it's covered by your insurance, like it is in other countries, not everybody is meant to run that test.
Okay.
So if you have a family history, you'll be asked to do it.
Okay.
And then very young patients, less than 40, you'll be asked to test it. Or maybe the very aggressive type triple negative breast cancer, you'll be asked to do those genetic testings. So there are special circumstances. And it's because we've realized that the genetic one is common in young women. It's also usually presents with the aggressive subtype.
Okay.
And then in those who it's in families, they may have that gene.
So if let's say your grandmother, your auntie, your mom, your cousin,
you definitely want to do that test.
You definitely want to do a test to find out.
Yes, and we'll probably ask that person to do the test first.
Okay.
Before you, the concerned family member.
Okay, I see what you mean. Because you want to determine in them if it's genetic.
Exactly.
If it was just random, then. So let's say you do the tests and you have the gene, or you then what?
Yeah. Angelina Jolie.
Yeah.
Yeah. So what do you do about it? The test tells you that
she had something done, didn't she?
So she had both her breasts removed.
Double mastectomy.
Before she got breast cancer. When you test positive for that gene, your chance of getting breast cancer is at least 80% or even more.
Okay. It's like a foregone conclusion.
You will get it. It's just a matter of time. So thank God you've done the test and seen it. So there's no need to sit around and wait. So ideally, you want to remove both your breasts.
Okay.
And there's always the option of reconstruction. That's what she did.
Yeah, okay.
So she had a bilateral mastectomy and breast reconstruction. And that is available right here. We do it all the time.
Okay.
So you can do that. Some people are not yet ready to make that move. So we do give you one of the hormonal drugs called tamoxifen, which sort of sits on the hormones that are responsible for these changes in the breast. So you can have that for a few years whilst you make up your mind to have both your breasts removed.
Okay. So, I mean, I guess if you're listening to us and you have quite a number of close family relatives, it may be something you want to explore.
Definitely.
So that you don't have to fight that battle. But okay, so let's getting back on track. So you've been diagnosed, you've been told what stage you're at, and then treatment options available. In the course of the interviews, I've noticed some people are on hormonal hormone therapy or hormonal.
Yeah.
Some have gotten their breast removed. How is it determined
who gets what?
Yeah, who gets what?
Good question. So should we start with surgery?
Yeah.
So when we are aiming for a cure, we need to remove the source of the disease, which is the breast, in the breast.
Okay.
So if the lump is small,
tell us about the surgery. You remove the whole breast, the outside and the inside.
So you end up with a flat chest.
So you dig inside, remove all of the tissue.
Yes.
Down to the rib cage.
Oh, not the rib cage. There's a muscle on top of your rib cage that the breast lies on. So we leave the muscle.
Okay, so you remove everything else.
Yeah.
Nipples, everything.
Yes.
Okay.
There is a type of mastectomy we can do and leave the nipple. That's called skin sparing. And we tend to do that when we want to do the breast reconstruction immediately.
Okay.
So for removing the breast, we can remove it and leave a flat chest. And that's it. Or we can remove it and do a breast reconstruction. And so we put an implant in. And this can be done at the same surgery. So I take off the breast, then my colleague plastic surgeon steps in and creates a new one with an implant and all.
Okay.
We may leave your skin with a nipple, but most of the time we take it off. But they have a way of replacing it. You can't use it to breastfeed, but it's something there aesthetically you can put in your braids,
Because it can be in the nipple, right?
It can.
Yeah.
So most of the time we do take it off.
You just want to, get everything.
Yeah, unless there are those that we see it really early, especially on the mammogram, screening mammogram, and then we are more likely to leave the nipple there. Right. So that's the mastectomy. Alone, or removing the breast with the breast reconstruction. And then we can also just remove the cancerous lump. So if the lump is really small, let's say 1 centimeter, 3 centimeters, maybe even 4 centimeters. When we get to 5 centimeters, you are pushing your luck, unless you are really, really busty. So really small lumps, but we have to do the mammogram first to check that that lump is the only lump. Some people will have just one small lump, but when you do the mammogram, you realize it's scattered throughout the breast, and there's no point.
Okay.
So if we are sure the lump is just one tiny lump, we will take out the lump with a bit of a rim of normal tissue. We'll take out that lump and leave the rest of the breast for you. Thing is, that breast we leave is high risk of getting cancer again. So to deal with that, that's where the radiotherapy comes in.
Okay.
So it's a special sort of X-ray, and it treats the remaining breast.
Okay.
Sort of bends things out, if I can put it in that sense, so that the chance of it coming back in that breast is really reduced. So it would have been equal to removing your whole breast.
Okay.
The effects.
The effect, yeah.
Yeah. So either we remove the lump and do radiation, or you remove the whole breast. And some people, even with the flat chest, still need radiation because the cancer was really advanced from the beginning.
Do you find that women are a bit hesitant to part with their breasts?
Oh, yes, and understandably so. We are all women, a bit attached to our breast. So it's not an easy decision. Don't take it lightly. But they just have to weigh the pros and the cons. It's your breast or it's your life. And then hopefully make the right decision.
Yeah.
Yeah, it's been more difficult for some than others.
Than some, yeah.
Yeah. The breast reconstruction too has helped a few of them overcome that. But it is really a problem. But then also, you think about it, if this person had come when it was really small, they wouldn't have to make that decision.
Yeah.
Could have just had the lump out, radiation, and they'll be good to go.
Good to go, yeah.
Yeah, so that's another advantage of coming early.
But I also feel like, I mean, once you know you've had cancer in your boobs, keeping your boobs may be a little bit... Do you find that, like, people have peace? Like, knowing that, okay, I had a lump, it's been removed, I've had radiation, all of that, but is there not something lurking at the back of your mind that as long as the breast is still there, it could come back?
Yeah. So it's interesting that even on the flat chest, it can come back on that chest. So you can't guarantee anybody that breast off or the breast is still there, it will never come back. But we are all different. So we have some women who, they don't want to see either breast. There are some women who, a tiny lump, I say, all we need to do is remove the lump. You can keep the breast. They say, no way, doctor, I don't even want to see both breasts.
Yeah. Well, I think one of our ladies did that, yeah.
It was that scenario. She didn't really need both of, but she just feels she'll have a peace of mind having both of. It's not necessarily the prescription I would give. But a few women say they don't want to see their breasts. That's their choice. We take them through counseling to be sure they know what they are talking about. Because if we take your breasts off, we can't put them back.
Yeah.
Right. So really, you don't need to remove both breasts.
Wow.
But some people do, having the remainder of the breast, maybe are anxious. Can it come back? With a flat chest too, it could come back.
It could come back. So it's really just...
Yeah, if you don't need to take it off, you can keep your breast and then have a full life. But you see, we are all different. So we also consider patient preferences.
Okay. I get that.
Yeah. So we explain the pros and cons. Look, your lump is 2 centimeters. We can take it out, do radiation, you're good to go. Somebody said, doctor, I don't want to be bothered with it. I want it off. And we will do so. Some people too, we tell them, look, this cancer is all over the place. We need to remove your whole breast. And it's a big fight. They don't want to part with the breast.
I mean, one of the stories that we told, they did tell us that somebody who was in the support group, her husband didn't want her breast to be taken out, and she died. And along the way, because ultimately taking it out would have saved her life. But I guess he was very attached.
Some women have taken a wrong decision because of the influence of husbands and other family members.
Yeah.
Yes, I've even met some people that it's not their husband, it's other family members who push them to take that wrong decision. Yeah. So women, we need to...
Because there's I mean, I also picked up in the conversations, there's the fear of not being sexy or not being attractive and thinking, oh, my husband is going to want to go and rest his head in somebody else's bosom because I'm bosomless.
Yeah.
So
it's a very real
it's
and genuine
very
concern.
real. Yeah.
Even if you were the one, some men are amazing, very support. Even if you had such a good husband, and he didn't say anything like that, you still think that he might be thinking this. And then there are those men who actually do say
that. Let's not talk about them. But so let's we'll continue on this path. But also just wondering about fertility, like breast cancer, fertility, chemo, radiation, all of that. Is it tied in? Is it a concern when women come to you that, okay, I'm having these issues with my breast? Is it going to affect my ability to have children, to conceive, to carry a pregnancy to term, all of that?
Yes. So we're dealing with women, so fertility is an issue. So some already are battling with infertility. So if you're already there, you don't blame the cancer for that.
Okay.
Now let's say you are very fertile and all. Whilst on breast cancer treatment, we don't want you to get pregnant whilst on treatment for good reasons. It can interfere with your treatment, delay your treatment. It can affect the medication. Some medication, some treatment can affect your baby and all. So we don't want you to get pregnant whilst on it. We have those who didn't know and they didn't know they had cancer or didn't know they were pregnant.
Yeah.
So either way, we ended up with a pregnant woman with breast cancer. We do know how to treat pregnant women with breast cancer. So there are some women who've hidden it because they were afraid we might harm the baby or ask them to get an abortion. We wouldn't do that. There's certain chemotherapy that's safe in pregnancy, and we give it to the patients, and all the babies survive. It's the mother I'm worried about, but the babies, they're all really nice and healthy.
Okay.
So for those who don't have children yet and want to have children after breast cancer treatment, we ask them to wait a couple of years at least.
Okay.
If you could wait, you are young enough and you can do more than 2 years, that's great.
Okay, so that it kind of washes out of your system.
Exactly.
Okay.
And then especially if you're on hormonal therapy, the hormonal therapy is going to reduce the chance of it coming back.
Okay.
After you've crossed 2-3 years, then we are hopeful that hopefully the disease is not coming back. And if you're on hormonal therapy, you take it for at least 5 years. So we need to get it into your system for the first 2-3 years. Then we have a discussion and we'll plan it. You take a break, have your baby, come back and continue. But there's fertility preservation. I mean, if you are 25 after chemotherapy, definitely you'll be fertile.
But obviously if you're 40 and you're hoping to have...
So already your ovaries are not that strong.
Wow,
so you want to consider pardon me. So you might want to consider even freezing your eggs before we give you the chemotherapy.
Okay.
Because chemotherapy has been known in older women to reduce fertility a bit. Not all, in some. And then there is some medication some injections we can give alongside chemotherapy to reduce the effect on the ovaries. So there are options.
If you can afford to, if you're older and you're going to go through the treatment and you're hoping to have children, if you can afford to, then it would be a good idea to consider the fertility preservation.
Exactly.
So that is something that can happen outside of your body whilst you heal your body. Because if you're freezing your eggs, you might want to have a surrogate or something.
Or even
like
carry them yourself later if your body is fit for that.
Yeah, but then at least you have the option later on whilst you... Because I don't know, but have you come across women who have had to choose between, growing this baby inside me or preserving my life? Is there ever a point like where it's like maybe you're like really far gone in the pregnancy and you're far gone in the cancer, and then you have to choose?
I mean,
I've seen things like that on Grey's Anatomy and Chicago Med, but I don't know about real life.
I don't think they've had to choose per se. It's a conversation.
Okay.
We give you options and see how we can balance everything. The worst case I saw, not to scare you, was a patient who came and it had already spread.
Okay.
And it had spread to her brain. And she was already middle of her pregnancy. So we gave her chemotherapy to help slow things down. And everything was good. It had spread to her brain. It wasn't too good for the mother, but the baby was fine. But when the baby was about 36 weeks, so which means the mother was almost due, then the disease in the brain just flared up. And the mother started having seizures. It wasn't very pleasant. Then at that point, we knew that we were going to lose her.
Okay.
We gave all sorts of medication, but we knew the end was coming. So at that point, we had to do an emergency cesarean
C-section, yeah.
and save her very healthy baby. And eventually the disease took its course. That's just one case. This is a few years back. But for all the other cases I can remember, we've been able to manage their pregnancies together with chemotherapy surgery. We've operated on pregnant women before, done a mastectomy. I've even done a case where at the same surgery, they did a cesarean, took the baby, and we also removed the breast.
Okay.
So there's always a way, and
around.
everybody's plan is different.
It's different, yeah.
Yeah.
Key thing is get checked early so that you have all these options available. So, I mean, once I'm going to start taking questions soon, but so once, you start treatment, what's that really like to be on chemo, to be having radiation and all of that? How was that like?
Okay. So the treatment is really long. To take you more than 6 months to complete everything, because the chemotherapy is every 3 weeks. The women have been amazing. They are strong. They have to be strong. Every 3 weeks, come for a shot. They do have side effects. I think your previous speakers
shared some of them.
Your hair falling off and all. Some dark nails,
their
fingers,
the bloating, the constipation or diarrhea.
Yeah, a whole lot
of libido. Yeah, lots of things.
The good thing is it does pass.
Okay.
Eventually, it passes. Their hair grows back.
Their skin is glowing. It wasn't a joke. I mean, the survivors that shared their story, they looked amazing.
Yeah, they do. You wouldn't believe that they've been through hell and back.
Yeah.
But they are able to go through. The side effects are there. They are manageable. Everybody's scars and war stories are different, but they come out all the better for it. Most people will get chemotherapy, and there are various types of chemotherapy and various types of cancers. So we'll have to see what fits yours. And then for the radiation a lot of people will get it because they don't come too early. But of course, if we are just taking a lump, definitely you need the radiation.
Okay.
And then after taking the breast off too, you need a radiation. We do use radiation also to treat cancer when it's spread.
Okay.
If it's gone to your brain, we can radiate to your brain.
Okay.
I mean, radiate the cancer in your brain.
Yeah.
If it's in your bone, we can radiate that spot of the bone. And all that helps. You did ask about the hormonal.
Yes, I did.
So at the point when you do the biopsy, we get a whole lot of information about the type of cancer.
Okay.
And that helps us decide on your treatment options. Then we do the CT scans to decide on how far it's gone, which also gives us more ideas as to your treatment options. So with regards to the drugs, the biopsy report, there's a second page which has estrogen receptors, progesterone receptors, HER2 receptors, and so forth. So those that have estrogen and or progesterone receptor, we say they are hormonal type and they need hormonal treatment. And these are tablets taken at the very end of your treatment.
Okay.
It doesn't have those chemotherapy side effects. It's like somebody taking a multivitamin or blood pressure pill every day. But they have to take it for at least 5 years, one a day. So what it does is
one a day for 5 years
or more.
Wow.
Yeah, but you take blood pressure medication
every day for the rest of your life.
So this one even has an end date. It's really not that bad like the chemotherapy. It's just that you have to remember to take it.
Okay.
And so what it does is it sits on those hormone receptors and suppresses the cancer from growing or from coming back.
Okay.
Yeah, and it's a very good medication. And those who take those hormonal drugs actually do very well.
Very well, yeah. I think one of our those who shared our story that she did so well on the hormonal drugs and felt so much better that she stopped. And then the cancer came back. Yeah.
Yes, that happens.
I think she said that was her biggest regret. So
yeah,
I mean, definitely get that. Let me take a few questions that are coming through. Someone's asking, can dirty bras cause breast cancer?
Right. So good question. There's a lot of fuss about braziers causing breast cancer and all. So the answer is brazier in no shape, size, or form can cause breast cancer or prevent breast cancer. Whether you sleep with it or not, whether it's dirty, whether there's a bone in it, whether it's too tight or too loose, it doesn't cause breast cancer. Breast cancer starts within the cell. Within the gene, something just goes wrong and then the cell starts multiplying out of hand. So no external object or pressure or stimulus on it can cause breast cancer.
Okay. This one says, is there anyone that has been totally cured from breast cancer before? I think you've...
Lots and lots of people,
that,
yes.
Yeah. Okay. This one says, I followed this conversation about breast cancer both on this program and Home Affairs, and my sister Jane is a strong advocate on this condition. She said that she's listening to it. He's listening to it and is worried for his young students and the young ladies that he's close to. So 2 questions. Are children just developing breasts susceptible to breast cancer? And what age was your youngest breast cancer patient?
Right. So thankfully, children don't get breast cancer.
Okay.
Sometimes when you go and do a search all over the world looking for that one rare case, you might find that one rare case. But children don't get breast cancer. The youngest patient I have had was 18 years.
Okay.
Maybe I've had just a couple of that. We do have a few patients. It is. We do have a few patients in their 20s. I think just 3 days ago, I was with a patient, a young lady in the university. She's 22 and she has breast cancer. We've started her on treatment. Yeah,
that's quite young as well.
Exactly. So we have a good number of them in their 20s. That's why we need to create the awareness amongst the youth before they get the cancer, so that, God forbid, should it happen, they know what to do.
What to do, yeah.
What to look out for.
But I think in the course of our conversation, it's quite obvious that there's a certain age above which you become more susceptible
to it. Exactly. So in Ghana, the peak age group is between 40 to 50 years.
40 to 50.
Now, when you go to the United States, this is going to be a decade later.
Oh.
So we find that Black women, African women, African American women, African women, we tend to get breast cancer at a younger age than white. So all these have some genetic, there's something going on in the genes. So we've realized that, and it's not only for breast cancer, but various diseases show up differently in different races, in different ethnic groups. For instance, even stomach cancer, gastric cancer, the Asians get it a whole lot more than the rest of the world. So it's different. But we see that Black women get it at a younger age, and they get the more aggressive subtypes than the Caucasians.
Wow.
So that's something we have to look out for.
Yeah, that's very...
Yeah, but the total number of breast cancer in the Caucasians, or in the United States, Europe, for instance, is more than the total number of breast cancer in Africa. But when you look at the deaths, it's the other way around.
It's the other way around.
So we have fewer cancers, but we have twice as many deaths as they have over there. And you know the difference is the mammogram.
Wow. Do we have a lot of mammogram machines in Ghana?
Oh, hardly enough. No, we don't. You can even have a whole region without a mammogram.
Wow.
So in Accra, we are blessed, and we have quite a good number. Not only in Accra, in the cities.
The bigger.
The bigger cities. So we certainly don't have enough mammograms. And we don't even have enough radiologists if there were 1,000 mammograms all over the country. But that really is what made the difference in other countries. So we need more mammograms. And it's not about having the machines, but we need to have a habit of screening.
Right.
Yes. And I realize that we are even afraid of the mammogram machine.
Yeah, we are. Oh, we are. Ignorance is bliss. But we're changing that because obviously from the conversation we can tell that getting early detection is absolute key. Exactly. Well, thank you very much for joining us tonight.
You're most welcome.
I'm really, really grateful. Can people just come and see you in Korle Bu? They have to be referred.
Korle Bu is a referral center.
So you should go to your
doctor. If it's a breast issue, you come to the surgical block.
Okay.
The trick is come and ask for the breast care nurses.
Okay.
They can see you without referral. They are doing breast screening. They can examine you. So if they pick up something, they will show you how to get into the system. So they will direct you. You do a scan. You get your referral. Bring your health insurance. And then they'll walk you in to see us.
Okay. So I think that's very valuable. The trick is go and see the breast care nurses at the Korle Bu Surgical units. They will guide you through the process, and then if you need to see a doctor, you will. But otherwise, just visit your local facility for screening, and then if necessary, you'll be referred.
Exactly.
Thank you so much for joining us. We're very grateful.
It's been a pleasure.
Thank you. We'll see you next year. I think breast cancer awareness shouldn't just be 1 month.
It should be every month. So I agree totally.
It should be not waiting till next year. But I also want to say a very big thank you to all of our families that joined us this month. The wives who had the breast cancer, the husbands who are so supportive, Edward, Jocelyn, everyone who joined us. We're so grateful. Tonight we're finishing a little bit early because I thought I'd play a song for you. For those of you who are fighting the disease, for those of you who have overcome, for those of you who have the diagnosis and are about to start the process, we're standing with you. We are with you. There are survivors out there who have made it. And when it gets really, really tough, it's a new song by Perez Music that I absolutely love. It's called Careful. And so this evening we're telling you that if it's really tough, don't cry. It will be well. My name's Anima Animado. This is Strong and Sassy. A very big thank you to everyone on the team and to everyone who joined us this whole month. Next week, we're back with a fun conversation. But until then, Perez Music with Careful.
Back in the days when I was hustling and bustling to find my way, so many nights you might be thinking and looking for a way out too. So I wrote this song for you. Sometimes I know there might be no one to turn to, but there's a man I know, he's ever willing to help you through. So I wrote this song for you.